Hi, my name's Alan Enriquez. I'm one of the cardiology fellows at Mount Sinai Medical Center in New York. We did a study looking at the impact of ventricular arrhythmias and ICDs on patients with the HeartMate 2 left ventricular assist device. So, the majority of patients who have an LVAD placed actually have an ICD, but the clinical consequences of ventricular arrhythmias in this patient population is not clearly defined in the literature. A lot of these patients can tolerate these arrhythmias without any decrease in LVAD flows or symptoms, and the effectiveness of ICDs in reducing mortality in this patient population has also not really been effectively studied. So what we did is we looked at retrospectively at about 106 patients at the Mount Sinai Medical Center that had the HeartMate 2 implanted from 2008 to 2012. And we looked at the clinical impact of ventricular arrhythmias as well as the association of mortality with post-LVAD ICDs. We define actually ICDs as an active ICD after having the LVAD, so patients who had their ICD inactivated after LVAD placement were put in the no ICD group. Essentially what we found was a lot of patients who have the HeartMate 2 have post-LVAD ventricular arrhythmias, around 35%. A lot of them will have palpitations, dyspnea, hypotension, or decreased LVAD flows associated with these arrhythmias. However, we had actually no episodes of sudden cardiac death. Accordingly, we actually did not find that the presence of post-LVAD ventricular arrhythmias were associated with increased mortality. And following that, after examining the association of ICDs with survival after LVAD placement, the presence of an active ICD also did not improve mortality in this patient population. This is despite the fact that around a third of patients in our study also got shocks, about 27% appropriate and around 13% were inappropriate. And so despite the fact that they did receive appropriate therapy, there's no benefit to ICDs in these LVAD patients. This is a hypothesis-generating study. This suggests that ICDs may not have a benefit, but the results have to be taken cautiously because it is a single-center retrospective study. But I think one thing we can take away from this is these devices may not have a benefit, and a lot of them do get shocked. So I think a conservative programming strategy for ICDs with longer detection times and higher detection rates is probably appropriate. More prospective studies with a larger number of patients is needed to actually confirm our findings.